in which you would like to examine the motor system. And in the motor system, you start with examination of the upper limbs. First of all, you inspect the upper limbs to look for any wasting, any fasciculations that are present. In case the wasting is there, you have to see whether it is symmetrical or is it asymmetrical. In case it is asymmetrical, you have to measure the muscle bellies with a measuring tape. Then you would like to palpate the muscles for any tenderness. You can tap the muscle bellies to look for any fasciculation. Once you are through with inspection and palpation, then you start the examination of the limbs, in which you would like to look for the tone, the power, and the reflexes. As far as the tone is concerned, passive movements of the joints can tell you about the tone of the limb. And especially, you have to ask the patient to relax the muscles. Once you have seen the tone of the muscles, then you go for the power of the muscles. In the power of the muscles, you start from the hands. Sometimes, if there is wasting of the hands or wasting of the muscles of the hands, then you have to go for a detailed examination of the hands. Otherwise, just looking at various groups would be enough. Ask the patient to flex his fingers, feel for the grip. Ask the patient to extend his fingers. Ask the patient to adapt the fingers. Ask the patient to abduct the fingers. Ask the patient to abduct the thumb. Ask the patient to abduct the thumb and then oppose the thumb. Ask the patient to adduct the thumb. Now that we have tested the small muscles of the hands, you ask the patient to flex the wrist, extend the wrist. Then you look for the strength of the muscles of the upper part of the arm. The flexor of the elbow. बाजू लंबा करो बाहर की तरफ, बाहर मेरी तरफ. Extensor of the elbow. ये हाथ पे जो मोड़ो. Pronator. Supinator. बाजू सामने की तरफ लाओ. नहीं इस तरफ. Flex the shoulder joint. बाजू अंदर की तरफ. Adduct the shoulder joint. बाहर की तरफ. Abduct the shoulder joint, and while sitting you can look for the extension of the shoulder joint. Once you are finished with the power, the tone, the power, you can go for the reflexes. For reflexes, it is important that the muscle should be exposed, the muscle should be relaxed, and then you feel for the tendon. For the biceps jerk, you ask the patient, ask the patient to relax his muscle, feel the muscle belly, feel the tendon, put your finger over it, and strike it with a hammer. And you look at the muscle belly for contraction. Now on the other side, ask the patient to relax the muscle, expose the muscle and its belly, feel the tendon, strike it. The root value of the bicep jerk is C5-6, while that of the tricep jerk is C6-7. Feel for the tendon, strike it. Feel for the tendon, strike it. Look at the contraction of the muscle. Supinator jerk. So you are finished with the examination of the upper limbs, the motor part of the upper limbs. Then you go for the examination of the lower limbs, in which the same pattern that you inspect the lower limbs, look for any fasciculations, ask for any tenderness of the muscles, then you go for the tone of the limb and passively flex and extend the joints, looking for the tone. Looking for the tone. Alternatively, you can roll the limb and look for the tone, and then you go for the power. Ask the patient to plantar flex the foot, नीचे दबाओ, ऊपर, dorsiflex the foot, invert the foot, बाहर की तरफ, flex the knee, अपनी तरफ खींचो, extend the knee, लात लंबी करो, flex the thigh, अपनी तरफ खींचो, use extensors to press down, नीचे दबाओ, extensors of the thigh, बाहर की तरफ, abductors, अंदर की तरफ, adductors of the thigh. Now the power, you know, it has to be graded according to a scale. When there is zero power, there is obviously no contraction of the muscle. Grade 1 is when there is flicker of contraction. Grade 2 is when the patient is able to move a joint but not against gravity. Grade 3 is when the patient is able to move the joint and also against gravity. Grade 4 is when the patient can move the joint against resistance. And grade 5 is obviously normal power. Once you are finished with the power, you go for the reflexes. And exposure of the muscle is very important. You have to expose it properly. Feel for the muscle belly. It should be relaxed. Feel for the tendon and strike it. Feel for the muscle belly. Feel for the tendon, strike it. For the root value of the knee jerk is L34. For the ankle jerk, the root value is S1. The muscle belly should be relaxed, muscles exposed, feel for the tendon, strike it. Muscle belly relaxed, feel for the tendon, strike it. So this finishes the deep tendon reflexes, and sometimes what happens that you are not able to elicit some reflexes, and in that case what you do is known as the General 6 maneuver. in which you ask the patient to ask the patient to pull right before you strike and relax immediately after you strike. जब मैं कहूँगा तो फिर खींचना, अच्छा खींचो, ढीला छोड़, खींचो, ढीला छोड़. Now, sometimes what happens that the reflexes are very brisk. In that case, you also have to look for clonus. And you have a patellar clonus and an ankle clonus. For a patellar clonus, with your left hand, you give rapid small strokes to the patella and hold it there. In case a clonus is present, the patella will keep on moving. Looking out for the ankle clonus, you hold the leg like this and flex the foot 3-4 times and hold it there. In case a clonus is present, the foot will keep on moving like this. So this is what finishes the superficial tendon reflexes. This is the deep tendon reflexes. Sorry, and now we go to the superficial reflexes, in which you have the plantar reflex. What you do is you firmly press against the plantar aspect of the foot, the lateral side, with a key, and you look for the movement of the toe. Normally what happens that when you pass the key firmly along the lateral border, the big toe should move down and the fingers, they come together. Similarly, the big toe will move down and the fingers will cradle together. But in case there is an upper motor neuron lesion and you do this reflex, what happens is that the big toe will move up and the fingers, they will fan out. And this is known as an extensor plantar response or the Babinski's sign. Okay. Then you come to the abdominal reflexes, in which in these 4 directions you flick the belly and you look for contraction of the abdominal muscles. Then you have the cremasteric reflex. Now that you are finished with the motor part, you can look for the coordination, in which first of all you would like to look for nystagmus, which is a prominent cerebellar sign. Then you would look for the scanning speech of the patient, in which you will ask the patient to say Constantinople or British Constitution, and the patient will break it down into small pieces. Then you ask the patient to touch your finger with his finger and touch his nose with it. नाक पे उंगली लगानी है, मुराद ये वाली नाक पे लगाओ, मेरी उंगली को लगाओ, जल्दी जल्दी. दूसरे साइड से जल्दी. This is known as the finger nose test. If the cerebellum is at fault, the patient will not be able to touch your finger properly or to touch the nose properly, and the finger will go in a different direction. The other test is known as dysdiadochokinesia, in which the patient is asked to do rapid alternate movements. In case the cerebellum is at fault, the patient will not be able to do it. Then you come to the heel shin test, in which ask the patient to lift his heel, place it over the knee and slide it over the shin to the medial malleolus. ये इस तरह करना मुराद, इधर उठा के इधर लगाना है, हाँ, शाबाश, नहीं ऊपर, हाँ, यहाँ से ऊपर उठाओ, फिर ये, ठीक. Then you do it on the other side. In case you have a cerebellar lesion, the knee jacks will become pendular, and it is very important that you also look at the gait of the patient. Once you are finished with the motor system, you would like to examine the sensory system of the patient, and in the sensory system you know that there are two tracts that are important. There is the spinothalamic tract and there is the dorsal column. The spinothalamic tract, it transmits the senses of position. The spinothalamic tract, it transmits the sensations of pain, temperature and touch. While the dorsal column, it transmits the position and vibration senses. You use a pin, which should be obviously a new one, and should be disposed after you examine the patient, and you ask the patient to tell you when he feels the prick. It is important that you let him feel at a place where the feeling is normal, so that he has the ability to differentiate whether the prick is normal at the other place or not. मुराद ये जब लगेगा ना, तो तुमने जब पहली दफा लगे एक कहना है, फिर दो कहना है, तीन कहना है, आंखें बंद कर, ठीक है? 1, 2, 3, 4, 5. It is better that you ask the patient to say 1, 2, 3, 4, 5 when he feels it, instead of you asking every time whether he feels it or not. You do it on the other side, and in case you have a glove and stocking type of peripheral neuropathy, you will find out that the sensation at the distal end is decreased, while that at the proximal end is normal. इधर और इधर एक जैसे लगता है? क्या किधर ज़्यादा है? In case he has got peripheral neuropathy, he will be feeling more distally, he will be feeling less distally, and proximally the feeling will be alright. Then you have to do it with a cotton wool. आंखें बंद कर. 1, 2, 3 बोलना. 1, 2, 3, 4, 5, 6. And you do it on the other side as well. Once you are comfortable that he does not have a peripheral neuropathy, you will go for the dermatomes. And if you do it at a few places, you can rule out the dermatomal distribution. For example, this is S1, L5, L4, L3, L2, L1. This is the umbilicus, which is at T10 level, the nipples at T4 level. In the arm, you have to look for peripheral neuropathy, and then this is C5, this is C6, the middle finger is C7, you have C8 on this side, and T1. So once you are finished with a pinprick and cotton, you just pick up something which is cold and find out whether the patient feels it, is it cold or is it warm. Now we want to examine the sensations that are related to the dorsal column tract, and in which you have to find out whether the position sense and the vibration sense, they are normal. For the position sense, you hold the big toe from both sides to stabilize the joint, so that the movement of the big toe transmitted into the foot and the other muscles does not transmit the position sense through other nerves. You tell the patient what you are going to do. ये मुराद ये ऊपर है, दरमियान में है, नीचे तुमने नहीं हिलाना. अच्छा ये ऊपर है, जिधर देखो, दरमियान में नीचे. You show him what you are going to do, then ask him to close his eyes. आंखें बंद करो, फिर बताना. And the movement should be random, so that the patient is not able to predict what you are going to do. If the position sense at this level is impaired, you go on to the joints above. Once you have tested the position sense, you go for the vibration sense, and you use a tuning fork of 128 Hz. and you place it over the big toe. But before you do that, it is important that you place it over the sternum and let him feel the normal sensations. Now you vibrate it again and place it over the big toe and find out whether the sensations there and the sensations here, they are the same. If the sensation here is impaired, you put it over another bony prominence which is proximal, the medial malleolus. If it is still impaired, you go to the patella, and this way you move onwards and find out a level where the position sense is impaired. And then after every CNS examination, it is very important that you ask the patient to walk and look at the gait of the patient. Gait of the patient is important, and you ask the patient to walk while exposing his legs. Then you ask the patient to walk in a straight line. Then you look for. Then you ask the patient to stand with his feet together. With open eyes and closed eyes. This will tell you whether the rhombox is positive or not. Rhombox sign is a sign in which you would be looking for a dorsal column lesion in which the position sense is impaired and the patient cannot stand with his eyes closed. In a cerebellar lesion, the patient cannot stand even with his eyes open and falls to the side of the lesion. The examination of the CVS, like all other examinations, you have to do the general physical examination, the compulsory part, and then you have to concentrate on the part that is relevant to the cardiovascular system. That is, you would like to look for osseous nodes, genuine lesions, the pulse, peripheral pulses, radioradial, radiofemoral delay, the blood pressure, the JVP, whether the patient is pale or not. Once you are finished with the general physical examination, you go for the same principles, that is inspection, palpation, percussion and auscultation. Although in CVS, percussion has become obsolete, and still we go for inspection, palpation and auscultation. So in examination of the CVS, you have to examine the precordium from the foot end of the bed, and you look for any scar marks or any visible pulses, and you look for the apex beat. Before we palpate the precordium, let us go over the areas of the heart. You have the first area, which is the apex beat, and this is the area which is present in the fifth intercostal space, the midclavicular line, and this is the area where the first heart sound is best audible. This is also the area where you like to look for murmurs that are related to the mitral valve. Then you have the tricuspid area, which is present at the lower end of the sternum on the left sternal border, and this is the area where you would be looking for murmurs related to the tricuspid valve. Then you have the pulmonary area, which is in the second intercostal space, left sternal border, and the aortic area, which is in the second intercostal space, right sternal border. This is in the pulmonary area, you will be looking for the pulmonary component of the second heart sound and the murmurs related to the pulmonary valve. While at the aortic area, you will be looking for the aortic component of the second heart sound and the murmurs related to the aortic valve. Once we have done the inspection, then we will go to the palpation of the precordium. In the palpation of the precordium, you have to put your hand over the precordium in a way that it covers the apex beat and a little area beyond that, because in a patient the apex beat can be shifted. Once you have localized the apex beat, which normally is at the fifth intercostal space, in the fifth intercostal space, the midclavicular line, you feel for the character of the apex beat. The apex beat can be normal, and you have to feel a lot of patience before you have the sense that the apex beat is normal. Or it can be tapping in character, in which the apex beat, it comes, quickly strikes your finger and quickly fades away, and it is forceful. Then you have a hyperdynamic apex, which is a forceful apex beat, and it stays there for some time. While you have the third type of apex beat, which is known as the heaving apex, that comes, lifts your finger, keeps it there for some time before it fades away. So once you have felt for the apex beat, you would like to feel for the left parasternal heave on the left sternal border. You can feel it with your palm or with the ulnar border of your hand. Then sometimes you can feel a palpable pulmonary component of the second heart sound. Besides that, you would also like to look for murmurs, which are palpable, look for trills, which are palpable murmurs. And you have to time it with the carotids. Once you are finished with the percussion, with the palpation, you go for the auscultation, in which you need a stethoscope, which should have a diaphragm and a bell. Once you have localized the apex beat, you put the stethoscope over it, and this is the area where you would like to concentrate on the intensity of the first heart sound, whether it's loud, whether it's soft, or whether it's normal. Once you have auscultated the area, the apex with the diaphragm, you'd like to auscultate it with the bell. The bell should be placed very lightly over the apex, and it is the bell which picks up the diastolic murmurs of low intensity. Once you have auscultated the apex, you move on to the tricuspid area, and here you would be looking for murmurs related to the tricuspid valve, which may be a pansystolic murmur or a mid-diastolic murmur. Then you inch your way upwards along the left sternal border, and you would be looking for the pansystolic murmur of ventricular septal defect or an early diastolic murmur of aortic regurg. While auscultation, you have to time your heart sounds with the carotids. The heart sound that comes with the carotid pulsation is obviously the first heart sound, and the heart sound that comes after that is the second heart sound. Then you come to the pulmonary area, where you would be looking for the pulmonary component of the second heart sound. You have to observe whether it is loud or soft. If it is loud, is it a split? And if it is a split, does the split vary with the phases of respiration? Then you also have to listen for the murmur, which may be an early diastolic murmur or a mid-systolic murmur in the pulmonary area. Then you come to the aortic area, and you listen for the aortic component of the second heart sound and for mid-systolic murmur, which may radiate into the carotids. The murmurs that are audible at the base of the heart, they have to be differentiated whether they are from the left side or from the right side. And for this, you ask the patient to sit up and auscultate the patient with the phases of respiration. The murmurs of the left side, they increase in intensity when the patient holds the breath in expiration, while the murmurs of the right side will increase in intensity when the patient holds the breath in inspiration. Then you percuss the bases of the lungs to look for effusion, and you auscultate for crackles. In case you are suspecting a tricuspid regurgitant murmur, you look for the liver, which should be pulsatile. And your examination of the CVS would be complete once you do the fundoscopy for changes related to hypertension and look for any drop spots in case of bacterial endocarditis.